Evening, everybody. Welcome to this very interesting panel, which we are taking up with a dermatologist now. We have had a brilliant panel discussion moderated by Pia, who's a convener of this program, and we have had a brilliant panel who has answered a whole lot of questions, which are sort of usual questions which people put up to us. In short, we will now go on to the dermat part of it because we see all kinds of, different kinds of patients and different kind of questions we come up with. And therefore, in that case now, I'm going to talk about what we need to do for those who have a problem with their dermat issues. So let me just share my screen with you. Just give me half a minute and I will be with you. Oh, it's going crazy. Okay. So let me go on to telling you a little bit about what really is PCOS and dermatological problems, or dermatoendocrinology as we call it today. We know that PCOS and dermatological manifestations form a very intricate interconnecting network which comprises many factors, and most of them of course are due to chronic inflammation, hormones and genetics. If you look at this very nice study done by the taking into account the American experience, published by Anuja Dokras in Fertility Sterility, she wanted to know what is the knowledge of physicians on PCOS. And what she found is after doing a survey of OBGYNs who were practicing infertility and those who were not, where 630 completed the survey, of which 70% were regular OBGYNs and 30% were fertility specialists, and 64.4% of them were female specialists. She found that almost 1/4 of them did not know which diagnostic criteria they had used to diagnose PCOS. The fertility specialists use the Rotterdam criteria twice as often as the regular OBGYNs. 85% were aware of the comorbidities which go with issues related to PCOS. And there were fewer OBGYNs who were aware of depression, anxiety disorders, and reduced quality of life. More fertility specialists recommended lifestyle changes versus OBGYNs, almost to the tune of almost 10 to 15% less in OBGYNs. Whilst we did a Mumbai experience wherein we looked at the knowledge about PCOS diagnosis and management, this is done through the PCOS Abhiyan, which is a group created by a collaboration of the PCOS Society of India with the Institute for Research in Reproduction in Mumbai and Tata Institute of Social Sciences and the Kasturba Medical Center. So we carried out a survey between family physicians and specialists, and the specialists included gynecologists, dermatologists, and endocrinologists. We had 100 of each, and the 300 rest of them were from the family physician level from all three fields of family physicians, that's Ayurveda, homeopathy, and allopaths. And what was found, I cannot divulge the results completely now because the paper has just gone in for publication, but I can tell you one thing, that there was a lot of issues found in terms of knowledge of the specialists and the physicians themselves. Of course, the specialists were better informed than the family physicians, but at the same time, overall, looking at a PCO patient was not complete by either of the specialists. Of course, it matters a lot when a patient comes to us. Say, for example, if a patient has come to me for infertility or menstrual dysfunction, probably I would focus only on that. But there are some of us who would also evaluate the other aspects of it besides only treating infertility. As a matter of fact, I was asked in one panel discussion that if at all you are dealing with infertility, why are you doing the other test to know whether there is any other issue? So this is something which we must all remember, that we have to treat patient as a whole and not only manage her local problem. So in short, we need to target the knowledge of all the internationally accepted Rotterdam criteria in order to make a good diagnosis. We need to make sure that there's consistent care as suggested by evidence-based guidelines, and all PCOS women should be completely monitored and managed across the entire reproductive period of their lives. It should not end with only treating the symptom the patient has come to with us. And hence early intervention to prevent is absolutely necessary to prevent long-term consequences such as insulin resistance, cardiovascular disorders, metabolic disorders, infertility, depression, cancer, and poor quality of life. So if we wish to really help our patients, of course, as the previous panel said, that we need to educate our patients, but we also need to educate the physicians. And that has been an agenda with us. And hence, I think this panel discussion today is an extremely important panel discussion, wherein we are going to have a discussion on healthy skin. And we have excellent panelists with us who are dermatologists. And I will introduce them one by one. We have Dr. Anil Ganjoo. I'm introducing him first because we always say ladies first, but here we have 3 women and 1 man. So I thought it's better I introduce the guy first. So Dr. Anil Ganjoo, who's a recipient of the prestigious Dr. Sardari Lal Memorial Lifetime Achievement Award. He also has the Economic Times Inspiring Dermatologist of the Year 2019. Besides that, he's received many other awards. He heads the Department of Dermatology in several prestigious Delhi institutions. He's the president of SARC and past vice president of IADVL and the scientific chair of aesthetics. And he's also authored chapters and he's reviewer of the AXI journal. Then we have Dr. Neena Madnani, who's a consultant dermatologist at the PD Hinduja Hospital and the Sir H.N. Reliance Hospital in Mumbai. And she's also the SIG coordinator for female genital disease and has established the first vulvar clinic in India. Neena has several best practicing dermatologist awards. In many awards she's received, and she's also the WCD speaker and has a Dr. Scatter Lectureship Award. So in short, her focus has been on various issues, but she's well known for her center, which she has developed as the first vulvar clinic in India. Then we have Dr. Malavika Kohli, who's the Director of Skin Secrets, which is a dermatology and aesthetics center par excellence located in South and North Mumbai. She's a course coordinator for IMCAS India, and she's also been the board member of the Indian Acne Alliance. She's a masterclass trainer for injectables and devices around the globe. She has authored various chapters in textbooks, and she's also a judge for the Vogue Beauty Awards. So the last panelist I want to discuss is our youngest panelist, Dr. Karishma Balani, and she also is involved in her area of interest is PCOS and doing all lasers and anti-aging therapies like Botox, threads, fillers, etc. And she's a member of various organizations, including the PCOS Society of India and the American Academy of Aesthetic Medicine. So this is one thing I would like all of you to know, that the PCOS Society is open to all the disciplines of medicine which deal with management of PCOS. And in short, it's not that we want only the physicians, but we're also looking at the associate memberships of people who are nutritionists, who are exercise therapists, etc., etc. So we go on to our discussion today, and we'll have the panelists joining in, and I would like to first of all discuss regarding acne. When we go to acne, in short, I would like to first of all ask the question. I'm trying to get the screen so that I can see the panelist. Unfortunately, I'm not seeing the panelist. One moment.
No, unless you stop sharing, you cannot see, Duru.
I know. So I wanted to show these pictures to everyone, so I think I will stop sharing and then we'll just talk about the symptoms. Just let me just finish with this and then I'll go to the actually, so that I don't have to screen share again. What I'll do is that after I share with this, with certain statements which PCOS Society of India has created a consensus statement on the use of oral contraceptive pills in PCOS women in India. And this is something which I recommend all of you to read, because this is something which talks about all the possible ways in which you could use OC pills, whom to use it for, not to use it for, contraindications, indications, etc., etc. And this was a collaboration with other organizations too, led by the PCOS Society of India. And we had 7, 8 to 8 other organizations with us on this, which was also including the NIRRH, the Endocrine Society of India, the IADVL, the Indian Society for Assisted Reproduction, the IADVL, then the Department of OBGYN, University Colleges, and the Indian College of OBGYN and the Mumbai OBGYN Society. The working group was quite a few. We had about 25 people working on this. And the other thing I want to bring out is that the recommendations from the international evidence-based guideline for the assessment and management of PCOS is something which we all need to read. It's brilliant. It's a 200-page document which talks about every aspect of PCOS. And I'm happy to share with you that out of the 37 organizations which were invited to participate in this development or this collaboration, the PCOS Society of India was one of them, besides Foxy being involved. So we have various programs related to PCOS, and besides having that, we also have the newsletter and the we were talking about patient awareness, and we do have patient awareness too. Let me go out into the Zoom now, and then we can discuss.
आपने चावल को क्या किया? नमक डाल के फिर वो पानी निकाल दिया. चावल कितना हो गया?
Please people mute their.
आप उसको, क्योंकि उसमें पानी है, नहीं तो वो ज्यादा नरम हो जाएगा. अब आप एक गिलास चावल का डालो, फिर बीच में
call up Sabha please.
और वो जो वो प्याज करके रखा है ना, वो
please mute yourself.
फिर उसको एक काम करो, नीचे तवा रखो, तवा.
Okay. So now we are back to our screen. I would request all the others who are on the screen to switch off their videos and to switch off their, mute themselves so that we can carry on with the discussion. Now, what I want to go on first with, discussing acne. Following acne, I will discuss hirsutism, and then we will discuss alopecia, and then we will discuss acanthosis. I think these are the common areas which need discussion, and this is something which are very, very prestigious dermatologists who have been involved in managing these patients will come in. So first of all, let me talk about acne. Malavika, can I start with you? Sure. If you have an adolescent girl coming to you and she's got acne, how do you know whether this acne is due to adolescence or is it due to PCOS? How do you determine the difference between the two?
Thank you, Dr. Duru, for having me here and amongst my esteemed panelists. And thank you, the PCOS Society, for organizing this wonderful session and the entire session of today, covering so many aspects of PCOS. You're right, we begin and end our day with PCOS at the clinic. And that's because it has so many ramifications and shades of gray. This is particularly true in the adolescent group, as you said. And yes, it is sometimes, with experience, one has learned that a lot of adolescent acne could either be the beginning as a sign of emerging or developing PCOS. It could be transient to do with natural pubertal, post-pubertal adolescent hormones, or it could actually be PCOS manifesting for the first time as acne. So it is at 14, a wait and watch game, especially if the girl has got a menarche at 12. But if the girl has got a menarche at around 10, then one really begins to wonder whether, this is a really PCOS already. Of course, as we all know, there's a role of genetics and there's a role of inflammation. And today, a lot of inflammation is coming from androgens, as well as from the diet, because the kids of today are following the Western diet, saturated fats, sugary foods. So this activating the FOXO1 and the mTORC1 pathway, leading to activation of bacteria. So there is a lot of pathways between genetics, inflammation, diet, and lifestyle, which we do see along with stress in a 14-year-old. So I would like to counsel the parents, and also I talk directly to the child. I do realize that, with acne, with hirsutism, and with androgenetic alopecia, it's a long journey. You got to walk the road together. So you have to develop a very good relationship in the first contact point with your patients, so that you start counseling them. They walk with you down that path. There's no quick fix out here. So once you build that relationship and bond, and you explain to them that this could be just adolescence, there may be an underlying PCOS background, we may have to test the hormones. I would say that do the conventional acne therapy, failing which you may then want to look at hormones, unless there are already signs of hirsutism, hair loss, excessive dandruff, and other signs of PCOS, which could then lead us to want to test earlier. But at 14, even if you do tests, again, the interpretation of them has a gray zone. So I think a wait and watch, and then if it's stubborn, not following the treatment guidelines and relapsing, then we would start investigating.
Absolutely. So Dr. Anil, what would you do if you have a young girl coming to you, she's 13, 14, she's got a lot of acne, and you are not sure whether it's adolescent? Would you start investigating right away, or you would use conventional therapy, as Malavika said? And when would you take the decision to further investigate her?
Investigations have to wait because in early menarche, unless the things have settled down, investigations are not warranted one. But PCOS has become so common in our patients that our questionnaire for taking history has evolved, and we now ask every acne patient of ours about menstrual history, about premenstrual flares, about severity of acne, about history of acne in their parents and how bad it has been. So all this keeping in mind that there could be a possible hormonal angle to it. And if we do come across any of these, even if you don't investigate, then we try and look into the possible hormonal issues that could be there. If the patient is very obese, so at least give them some unconventional insulin sensitizers to start with, like acetylcysteine, like vitamin D, these kind of things. And if we have to investigate, we of course have to wait, and we start treating the patient and keeping in mind that if there are premenstrual flares, if there are irregular cycles, particularly in a patient who has at least 2 to 3, 4 years past menarche. I feel 2 years past menarche, one should be ready to go ahead with tests if it really warrants clinically. So I do tests if we are more than 2 years past menarche and I suspect that there is some hormonal disturbance. And right in the beginning, if I feel that the hormones are stimulating the acne, I do look into the hormonal aspect of treatment, because unless I do that, my acne is not going to respond.
Absolutely. So in short, when it's a young girl, we would like to wait. We would probably wait for at least 2 years post menarche before thinking of giving her any kind of hormonal therapy, which is a good suggestion. But in the meantime, Nina, what do you use as conventional therapy? So we have patients who come to us, we would like to know, okay, what should we offer them in the meantime? Of course, we would refer to the dermatologist, but at least something we can start with.
Mic is on. You're on mute, Nina.
Nina?
You're on mute.
I think she's on.
Yeah. So an adolescent who comes to us with acne, after, like Dr. Anil said, you take a big history, then of course we are going to start treatment. Depending on how severe the acne is, if it's just mild, the child has just started getting some seborrhea, the child has started getting some closed and open comedones, then we would start on with a topical retinoid. We could add on a combination of a benzoyl peroxide and a clindamycin, and we would observe the child, because these are slow acting modalities, and we'd see how they do. you don't expect a miracle in 1-2 weeks. It takes time. It takes at least 4 to 6 weeks before you see some change. Counsel the patient that this is going to be a lot of hand-holding, because we need to know how her hormones are behaving vis-a-vis her skin. Because adolescents have a lot of ups and downs with their hormonal surges depending on their stresses, what they are eating. So we'd start with topical. If she has very inflammatory, where I grade her into the moderate, if I find that she's scarring, I would add on a topical, I would add on a systemic agent, like a systemic antibiotic, like doxycycline. We used to use a lot of azithromycin, but now we are going away from it because of the resistance of the Propionibacterium acne. So we use doxycycline. Again, doxycycline, parents get very shocked when we are giving doxycycline, because they say it's an antibiotic. How can you give it for so long? So again, you talk to them that this is an international protocol. So we'll give them doxycycline, we'll give them topical retinoids, and we will give them topical either benzoyl peroxide or clindamycin. We try not to give them only topical clindamycin, because again, you're helping the resistant bacteria. You're stimulating resistance of the it's called Cutibacterium acne now, not Propionibacterium anymore. So we do that. And, pardon?
I said acne vulgaris is something which...
Acne vulgaris is what we use as a term, as a medical term. So the moment we tell the kids you have acne vulgaris, oh, acne, it's never going to clear. So I have to tell them it's a synonym for pimples. Acne is a synonym for pimples. So we have to calm them down. Absolutely. So that's how I would address. And then if they fail and we find that it's getting worse, they have irregular periods, they have hirsutism, they've started getting alopecia, then I would start, my brain would start ticking in terms of hormonal, evaluation.
Okay. Just a general question, whoever wishes to answer. Basically, if you have a patient coming with acne, how many dermatologists really would fully examine a patient to see whether there's any other issue anywhere else on the body? Or only look at the acne and treat?
No, most of us.
I think most of us.
All of us
we look at
who are here would
yeah.
do it for sure.
It's imperative. It's imperative.
It's a complete examination.
Complete examination.
To look for any other issues. So suppose, Karishma, you have a patient who comes to you and you see a lot of acne, and you're also trying to look for any kind of hirsutism or something which is associated with it. So which score system are you using, which scoring, or are you generally using any kind of methodology of assessing the hirsutism?
Am I audible? Yeah, I'm audible. Ma'am, first, I would just like to go back to your first question regarding investigations in a patient with acne at the age of 14. Because I have seen a couple of girls who've come to me at the age of 13 and 14, and they've been obese. And I have seen acanthosis nigricans in them. I have asked for serum insulin level, the fasting and the post-lunch. I have almost found levels almost up to 200 and 300. And we've started them on metformin at a very early stage, and we've really seen very good improvement. So is there associated, can you hear me?
Which levels are you talking about?
The serum insulin level, ma'am. If the girl is obese and there's presence of acanthosis nigricans, so we ask for a serum insulin level. Maybe I may not ask for all the other hormonal tests which we would have otherwise asked for hyperandrogenemia, but insulin levels, finding them high and starting metformin at an early stage has really helped them, and maybe then they may not develop all the overt signs of PCOS later on. But and of course, then we keep a regular follow-up.
Yes. No, since you're talking about doing insulin levels, are you doing only fasting insulin, or are you also doing
fasting insulin, post-lunch insulin? Because I read in one of the books that the post-lunch insulin rises before the fasting insulin. So it's always better to do a fasting and a post-lunch insulin level.
But suppose you see, I know I'm mixing up acanthosis here, since you talked about insulin resistance. If you do see patients with acanthosis nigricans, then would you do an insulin level?
Sorry, ma'am, if I didn't get your question.
If you see your patient having clinical signs of insulin resistance in the form of acanthosis, then that is a clinical sign of insulin.
Yes, ma'am. that we understand, but for our patients to understand, because they have to be on a drug, metformin, which is an anti-diabetic drug, for a good amount of time. So it's very important to document it, and then you start, so that, you know, long term they adhere to that, they have a good compliance. Otherwise, they generally don't like to take any anti-diabetic medication unless they have the report in front of their eyes.
Yes, I totally agree with you. It's a fact that
Yeah.
you do not accept it when you tell them verbally. But at the same time, we must realize that basically the guidelines say that if there is clinical evidence of insulin resistance,
Insulin
or
resistance,
the person also obese, it's a
Yes.
good idea to even start with metformin. There's no issue.
Metformin.
At what age, youngest, have you started with metformin? Anyway.
13 years, ma'am. I've started for a girl, 13-year-old.
I have started at 10.
Yes.
Because she came with striae. She didn't come with acne, she came with striae. And because she was prepubertal. So she came with severe striae dystensia, the red ones. So I had to start at 10.
Okay. So coming back to acne is, you know, we know that acne gets corrected very well with even oral contraceptive pills. And they are also very useful for women who have got irregular periods. So as a matter of fact, that's like one drug which helps both the issues. So in short, we do put a lot of our patients as gynecologists on oral contraceptive pills. But there are certain pills we would not want to give and certain pills we would want to give in those patients. Which are the pills which are most popular with the dermatologist? Which ones do you like to use?
Spironolactone. We are very happy with spironolactone.
No, the pills. We are more into Diane, Yasmin, where we have low estrogen pills with low androgenic potential progestogen. So Diane with with ethinyl estradiol and cyproterone acetate, and Yasmin with drospirenone are the ones that we give. These are more helpful in acne because they have low androgenic potential. The ones that gynecologists mostly use is mostly for fertility and regularization of the periods, which may have more androgenic potential. So that's the difference. We avoid those and give these.
No, I agree with you that yes, we would prefer to use non-androgenic progestins, because when we use estrogen and progesterone, we know that the estrogen is usually the same, estradiol. But the progesterone, there are 4 generations of progesterones. Yes. And the fact that every one of them, when it gets metabolized and it has a side effect, which is either androgenic or it may be non-androgenic. And drospirenone has been found to be the least androgenic. And therefore, we prefer using that in women with acne. And it really helps them a lot. Again, the question comes up that when we have young girls whom we are giving oral contraceptive pills for a long time, there's a lot of apprehension by the mothers that you're giving hormones to my daughter for a long time. So Malavika, how do you convince the mothers?
Yeah, it's easier nowadays than earlier. And I think if the periods are irregular, your case is stronger. Of course, there's a lot of counseling involved and merits, demerits have to be discussed. I must say that I am a proponent that if the lifestyle modification, especially if there's a higher insulin level and the patient is obese and even has irregular periods and has a very poor lifestyle, I may actually, to break the ice, actually start them on a combination of metformin and spironolactone along with lifestyle modification. And if it doesn't work, then put them onto Yasmin or cyproterone acetate with ethinyl estradiol. This also helps to break the ice. This also makes them realize that, the periods are not regularizing, things are not settling down. But if the case demands that they need to start on it, then the first concern is that, will they get dependent on it? The second concern is, will it lead to infertility? In fact, they think the other way around, that the pill will lead to infertility. And the third thing is that they want to know how long they have to take it. So these questions have to be, so then very often I must say that when I feel that there is a genuine case, I do always take the help of colleagues, my gynecologist colleagues like you. We share so many patients because of that, is that I feel then it's a good idea for them to visit you as a gynecologist and our gynecologist colleagues, because this is really also your forte, and I think it's important that they hear it from you as well. On the other hand, if there's hirsutism and androgenetic alopecia and the need for an anti-androgen, then I may refer them to an endocrinologist colleague. Where the periods are regular, then I refer them to an endocrinologist colleague. So I think it's all about teamwork. So I think metformin and aldactone will be my first choice. If I cannot give OCP, if OCP required resistance, take the help and create a team for the patient. It gives them a lot more reassurance.
I agree with you. Again, when we use spironolactone for patients who are young girls who are not planning a pregnancy, it's fine. But when we give it to the older women who may get pregnant whilst they are on it, I think we need to combine the OCP because spironolactone can cause harm to the developing fetus. And therefore, it's important for us to remember that in those women who are, could get pregnant inadvertently, or they have to be told that they shouldn't get pregnant. And if they are not, sort of having having any contraindications to using the pill, then we need to tell them to avoid a pregnancy in other methods, use other methods to avoid a pregnancy. So in short, Nina, if you could tell us, which are these will be the few last questions for acne, and then we move on to hirsutism. Which are the patients you don't give the OC pill to? Are you comfortable giving OC pills to all your patients, or there are certain tests you do or certain history you look into before you prescribe OC pills? Because it's taken a pretty long time.
Yeah. I think that's a very, very important question, which a lot of physicians do not ask these questions. One is definitely I would not give it to a person, a girl who's 35 and a smoker because of the hypercoagulability of the smoking. I would ask for a history of a family history of a stroke in a younger parent or a family member. That's very important. And ask for cancers in the family. That's the other thing. And if a patient is very obese, I would be worried about giving the OCPs because some of them would make them put on weight. So, and plus I would definitely not give a OCP if I'm planning to give it for a long term without referring to the gynecologist who do a pap smear and see the baseline pap smear before we put the patient on the OCP. So history taking, and the reason I'm telling you this is because I've had 2 young girls who came to me with acne, and the first thing they told me is, don't give me OCP. So I said, why? And one of them said, I've just recovered from a stroke. I was given an OCP. So I said, but is there any family member who has had a stroke? She says, my father had a stroke at the age of 45. So I said, why did you not tell your physician to administer? She said, she never asked me, so I didn't think it was important to tell her. So it's very important, this history taking, because I think, stroke.
Yeah, you're right.
In younger people, we are seeing it in 25.
There seems to be some lag with your connection. So therefore, some of your words got cut off. But I think it's important for us to also realize that we need to examine the patient, because I had one patient who was treated by a dermatologist, and the patient had early breast cancer, I think. She was a young lady of 28 or 30. And she took the pill, and she was never examined. The breast was never examined. And then she came in with invasive breast cancer. So it was unfortunate that a very young lady, because when they there's not that the OC pills cause the malignancy. It was the hormones which made the latent malignancy grow up further. So again, with examination, I think the breast should never be missed out. The breast examination has to be done before breast examination, a complete examination, to make sure. Now, the reason I'm bringing this up is only because I find that I'm not sure what percentage of dermatologists are examining the patient completely or taking a full history. Based on the survey which was done recently, we found that only 25% of dermatologists are examining the patients completely. And that is the reason why I brought up this issue. So we move on to the next topic is hirsutism, which is even again because of hyperandrogenemia. Dr. Anil, would you like to let us know that when you talk about hirsutism and when we talk about the Rotterdam criteria, we say that it should be either clinical or biochemical hyperandrogenism. And it's a well-known fact that doing the hormone levels for androgens in the commercial way is not enough, because it's not good enough to give us the correct answer unless we are doing something like a free androgen index or a HOMA-IR. So in short, we want to know what do you all do in terms of trying to evaluate a patient when she's hirsute as to how severe the hirsutism is. Do you go only by clinical examination, or you still do all the tests? And which test do you do?
Tests are depicted by the clinical examination. So clinical examination is very important. And if you find signs of, number one, insulin resistance, if there's a history of menstrual disturbances, if the patient is obese, so you would investigate based upon these investigations. And a basic investigation profile is done in most of our hirsute patients before we take them for treatment, which includes a serum testosterone total, a sex hormone binding globulin, and insulin fasting PP with GTT now, because insulin levels are not very reliable. We do not do FSH LH now because it has been found to be relatively unreliable, and a thyroid stimulation TSH, and in rare cases a 17 hydroxy progesterone if we feel like that, if this misses anything out. But the basic panel is done. And as you said, many a time you come across patients who do not have any biochemical abnormalities, but if we clinically feel that they have hyperandrogenism and they need to be treated for that, I usually give them an anti-androgen like a spironolactone, which I feel works very well in patients who have this. This is an entity called cutaneous hyperandrogenism, where you don't have any biochemical, marker, and but still the skin is hyperandrogenic, and you have signs of right evident in front of your eyes. So these patients and the patients who do not do well, for example, with lasers, are put on anti-androgens like spironolactone in spite of being biochemically, normal. So this is a clinical diagnosis of hyperandrogenism, and we have to depend upon the clinical signs rather than the biochemical signs.
Yeah. So I agree with you again that we need to depend a lot even on clinical rather than biochemical. But there are patients, like say we follow this modified FG score is what is normally followed by everyone. Mm-hmm. But most of the patients will have already got themselves threaded, waxed, lasered, everything, and then come to us. So half the times we cannot make out that they have done something to themselves, because it's so beautifully done by all of you that we don't realize that something is done. As a matter of fact, we put up a question, because today with so many laser clinics being around and advertising so heavily, people have gone straight to the clinic, got their laser done, and then they will come to you for their other issues. So,
ma'am, no matter what they do, if there's a hormonal issue, they're going to come back with hair. That is the problem in our laser practice. The patients who have that problem will not respond. They'll just come back with the problem. So within a month, if you call them back after a month, you'll know that she has hyperandrogenism.
So I think that is an area which probably as a dermatologist would think about, that when would you say, okay, I've done enough lasers, now I need to look into it, because every patient is not investigated from day one. Okay, you've done a laser, you have found hirsutism, you have suspected PCOS, you haven't diagnosed it as yet. You have helped her because she's very distressed with all that hirsutism. But at which point in time do you feel it's necessary to investigate? After how many lasers? Doesn't it depend a little bit on the anagen phase and the growth of the hair? How fast it grows?
It is not the number of lasers. At the first instance, clinical history extremely important, family history extremely important, drug history extremely important, and the clinical signs extremely important. So that will depict whether I have to investigate or not. Having said that, almost all my patients go for investigation before I take up an LHR, in spite of they may not be showing other signs. Because if they have signs of hyperandrogen in the form of hirsutism, then they have an androgen excess, either an androgen excess or a hypersensitivity of the androgen receptors. So I get most of them investigated. And as far as lasers are concerned, we now know over a period of maybe 15-20 years that we have been doing laser hair reduction, we now know how a patient will behave. after about 2 or 3 sittings, there's a considerable delay between the, between the sessions, because people do not get regrowth. So if a patient is not doing well after 2 or 3 sessions, that is the time I would want to investigate if I have not done it by any chance at the beginning.
Absolutely. So Karishma, what do you do?
Ma'am, I do a complete examination. I actually look out for this modified FG score, and we write it down, and we explain, we show the chart to the patient as well, and we make them understand that this is a sign of underlying hormonal imbalance, and it's always better that we investigate at the first visit itself. And then if they say, no, doctor, we would like to wait, and let us first start with the treatment, all that, then we have a 1:1 discussion, and then we take a call. But most of the time, we try and get the investigation done in the first visit itself, if we are suspecting a PCOD, because that will guide our, further line of treatment, whether if we have to give any anti-androgens, if we have to give any other medications along with the lasers. Otherwise, if we just start with the lasers and we don't start parallel treatment with the medicines, they are never going to be happy.
May I add?
Yeah, lasers have been used for all kinds of patients. There's a particular kind of patient who may not respond well, especially the ones who are darker skin. I think they don't respond very well. Or is there a different laser for different skins, Malavika?
Sure. First and foremost, Duru, Dr. Duru Shah, my take is that hirsutism has become extremely complex to handle today for many reasons. One is, you have patients who've already done many lasers come to you. Patients have taken medication with laser, anti-androgens with laser, had a success, and then come back with a relapse. So, and then you have some patients who have a biochemical abnormality where you're justified in giving anti-androgens. And then you have patients who have nothing, like Dr. Anil said, and the dichotomy is whether you should do laser hair removal or give them time with anti-androgens, then start. So really, I feel that as I look at it today, thick dark hair responds to all types of lasers. So it's not your thick dark hair which is a problem. If you have darker skin, then the Nd:YAG, long pulse Nd:YAG is safer if it has a good cooling device with inbuilt cooling, and that's because it protects the epidermis and has a longer wavelength. Now we have the multiple wavelength laser, the triple wavelength lasers, which overcome a lot of the the problems that we face with laser hair removal in terms of efficacy. They're supposed to shorten the number of sessions. They also treat mixed hair. So the problem with hirsutism is also that you have, amongst thicker, darker hair, you also have softer, finer hair, what we call the vellus hair, hypertrichosis. Mm-hmm. So, nowadays, the multiple wavelength is supposed to overcome that, where 3 wavelengths are used. The Nd:YAG is good if you have darker skins. But it's also operator dependent. The tool depends on the operator as well. So when you master your tool and your device, you can always get good results. But we do find that in hirsutism, despite everything, you could be testing, could be doing the right laser, you could be giving the right caps, you do get resistant cases. You do get resistant cases.
I did have a patient who came with a big scarf around her neck like this one day, and I said, why are you covering your neck? She opened it and she had black spots all over her neck, and she was so furious because that's what had happened to her after the laser. Now, why does that happen, Nina? When they do laser, why do you get these spots in some patients? Not all, of course. Why does it?
So what happens is, like Malavika said, it's very operator dependent. So you have to know your laser physics very well. And if you don't choose your parameters well, vis-a-vis the skin type and the hair type, you are definitely going to get burnt. And this happens especially with the diode lasers. Because with the diode lasers are beautiful lasers, but you have to be really very careful of the parameters you're using. So if you're not sharp with your laser physics and you don't evaluate the skin and the hair, we have seen so many burns.
Including with the IPL.
Yeah.
So you have to be really careful. How many laser machines in your office?
Beg your pardon?
How many laser machines in your office to take care of different skins?
I have 3.
We have all, at least, because most of us in laser practice have all the wavelengths. At least we have multiple systems now.
So how many are there? 10?
If we take all my lasers into account, I have around, yes, 10, 12 machines.
Very good. There'll be hardly any place for the patients then, probably.
And also it's body hair and it's facial hair, so you need lasers of different hair types, and also your volume of laser hair removal, which also makes you, and also the need. I must tell you that there are when the hirsute patient gets better after about, you were asking a question, after the 4th to 6th session, if things are going right.
Yeah.
After the 4th to 6th session is when you know that you know things are working. You know it.
Yeah.
And then what happens? The hair gets less thick, and it goes into that zone where it's dark but finer, but still not soft and fine. And that's when you can run into trouble. So sometimes we need to switch technology. So it's not that we just love our gizmos. It's that we need to switch technology.
The brain behind the machine rather than the machine.
Yeah.
I mean,
Your hands and your brain.
Also the parameters.
I think a lot.
Even the parameters.
Even with the ultrasounds done, you see, we get so many ultrasounds today, which are really crazy. It depends so much on who's the man behind the machine or the woman behind the machine to give you a good ultrasound report. So coming to insulin resistance, when we talk about acanthosis, I know that metformin treatment is the ideal choice to be given. But suppose a patient cannot take metformin, she can take a very small dose, or maybe she's not exercising even though we have told her to exercise. We've done everything possible. What else do you do for these patients? What else can you give to these patients?
I think now the trend is, and we are also adopting it, is giving inositol. So we are also using inositol in our practice because it also causes insulin sensitizing, and that seems to work quite nicely in the younger people. So, and they also tolerate it much better. They are happier when they're told that it's not a diabetic drug, it's a vitamin type of agent. So that is something which I go to.
Okay.
Even alpha lipoic acid.
I think, N-acetylcysteine,
vitamin D.
Of that, alpha lipoic acid, vitamin B6 and zinc, along with also D3 and
D3 is very important.
D3 once a week for 4 to 6 weeks and every monthly, along with the combination of these. The younger generation, I'm absolutely in agreement with Dr. Neena. It definitely helps to cut the sugar craving, and I want them to take it right after the last bite of that meal. So they must have it right after. And if you give it to them twice a day, when the sugar craving goes down, automatically things begin to go on the right track. The sugar is poison.
But I think, Dr. Duru, the most important thing, it's not whether the patient agrees or not agrees. The most important thing in insulin resistance is lifestyle modification. You have to be very, very strict and harsh on this. The parents are to be told, please don't come to me if you can't do this. Because if they don't do that, we can do nothing with insulin sensitization, So we have to tell them 90% of your treatment is weight reduction, lifestyle modification, and only 10% is something that I can do. If you can, please do follow. If you can't, then you can't do well. What do I do with my install if she doesn't improve her lifestyle and lose weight? It doesn't work.
That's where we need Tara to come in.
Yes, absolutely.
After hearing her lovely talk, I think that's what we need Tara to come in.
Ma'am, I feel, ma'am, all of us in our clinics, we should have that, body fat analyzer. It's a very simple machine. You just have to enter the certain things and you get, spot on, you get your BMI, and that BMI can really scare them. A measuring tape which just tells them about the waist circumference. They say more than 80 centimeters in a female and more than 90 centimeters in a male. It's an indicator of metabolic syndrome. So if we can, tell them all these things in our clinic itself and have a counselor in our clinic, I think PCOD needs a lot of counseling. We really need to make them aware and scared about the future problems they can have.
I totally agree with you.
Insulin.
All our patients, and in short, we calculate the visceral fat also, show them how bad the visceral fat is and how it's going to affect your liver, show them the fatty liver on ultrasound. And I think once we do these, show it to them, it makes a lot of difference. I think we'll need to ask one more question on this insulin resistance is, when patients have acanthosis with metformin with the right dose, in how much time do you expect the acanthosis to disappear? And second is, what do you do with the skin tags they develop with acanthosis? Whoever will.
Ma'am, can I answer? Within a week or two, they start saying that after starting of metformin, they can actually feeling light in their weight. That is the first feedback they give. They're feeling lighter and appetite has reduced. The skin, I think it takes a couple of months to show the result. That's not so quick because it's a thick layer and it has to. We generally do other combination of treatments.
What is the combination treatment you use?
So we do a combination of chemical peels along with fractional lasers.
Okay.
And topical creams like retinoids, alpha hydroxy acid, salicylic acid. We give a combination of all these along with a moisturizer. And yeah, it takes a couple of months, but it doesn't go away completely. It takes a while for it to, but it fades away. Maybe 50 to 70% it gets better, only if they are losing weight and following the lifestyle modification.
And the skin tags need anything?
I think, can I add to that, Dr. Duru? So if you're starting metformin, the changes in the acanthosis nigricans is not before 6 to 9 months. It takes very long for the changes to come. Skin tags are very easy. We can remove them immediately in our clinics under local anesthesia. It's a very quick process.
How do you remove them?
We get them a little local. We have our hyprecators. We have our Elman radio frequency machines. You can just sort of get it out. But what they are concerned more is about the darkening of the skin. And we know that insulin also stimulates insulin-like growth factor 1, which is the one which is causing the thickness. So even if we are doing all these procedures, it may not help them to get a consistent result. So we have to counsel them that your metformin is going to take you 6 to 9 months. And it does. If you see the patient after 9 months, they're definitely much better, even without any procedures.
Absolutely.
Ask me, I think the acanthosis nigricans improvement is directly related to their weight loss. So they lose body fat percentage and they go down 3 kilos, 5 kilos, 8 kilos, 10 kilos. You'll just see the acanthosis following exactly 3, 5, 8, 10. It's lighter, lighter, lighter. Once they've dropped 5, then only I be 5 kilos and the body fat percentage goes down, then I start procedures. Otherwise, it's
I believe procedures and topical treatments are very useful, and the patients who get them improve very fast and are very happy. Within a month or 2 months, most of my patients see a change. I don't have to wait for 9 months for the metformin to work. Metformin will be on, but my procedures and my topicals right from the beginning. And I feel that within 2 months, most of my patients will be very happy. They won't be cleared completely, but they'll be very happy about the improvement in the texture and the color.
Absolutely. I think the message going out is that patients who are insulin resistant, either because of PCOS, combined with obesity, 80% of our patients are obese. It's the fat, which is internal fat, not the subcutaneous fat, which is known to be causing insulin resistance. And by dropping the fat, you're lowering the insulin resistance. By dropping the insulin levels, which actually work as growth factors, you're making the patient better. So in short, I think all this together works. Does any of you use any other combination with medication with these patients besides the local therapies and metformin and whatever else? Anything else? Do you all tend to use anti-androgens at the same time? Because we know hyperandrogenemia and insulin resistance go hand in hand. There are some people who use statins that is known to have some effect on androgens. So there are various combinations people use. But I think what is important for us to know is that these combinations also work with mainly with hyperandrogenism. So when we use something like flutamide or finasteride or whatever other drug we use, all of them, of course, we need to be sure that it's safe to use it for them and evaluate them regularly before we can sort of keep continuing the drug. So we come to the last part is, I don't know how much time I have left, but in short, we will cover the alopecia part. Many women are having alopecia coming up, hirsutism on the face, but alopecia on the head. So how do we deal with alopecia? And this is something which I want to discuss in terms of, one is that how do you diagnose female pattern baldness? Second is how do you treat it? And is it topical? Is it oral? What kind of therapy do you use as a dermatologist?
Female pattern alopecia is a clinical diagnosis, as we call it, pattern. So if you have a pattern of alopecia where there is increase in the parting in the center, and there is recession of the hairline over the temples, and then there are other signs of hyperandrogenism, even if they are not, then but still you have you will make a diagnosis of patterned alopecia. And when there is patterned alopecia, it is called androgenetic, but it's not as proven in women as much as it is proven in men that it is an androgenic alopecia. So the 5-DHT pathway being involved in development of androgenic alopecia is fully proven in men, but not as much in women. So that's why finasteride is not very useful in women as it is in men, and is not the first line. There are several other pathways that have been thought of. But having said that, anti-androgens do help, and I depend more on spironolactone than on finasteride in women. In men, I give more preference to finasteride. And we use topicals like minoxidil. We now have peptides which help. And then we have some procedures also with which we can help these patients.
So anyone else wants to add anything to whatever Dr. Anil has said?
Yeah, I want to add.
Yeah.
That in we call it female pattern hair loss, because a lot of times we don't find any biological evidence of hyperandrogenemia. And there are three types of clinical appearances. One is you may have widening of the parting, the other you may have recession of the frontal, and third is you may have diffuse loss of hair. So there are three different types of. Now the most important diagnostic thing for female pattern hair loss is you use your dermoscope, because you'll have a diameter variation in the hairs. So you'll see that more than 20% of the hairs will be thinner hairs. So when you have that diameter variation, you're a little more sure that this is more female pattern hair loss, and these are not other types of alopecia. So that dermoscopic examination is very important for evaluating that this lady has a female pattern. And we can show it to the lady also that, see, so many hairs are thinner. Also that normally you have multiple hairs in clumps growing together in one follicle. So in female pattern hair loss, we'll have single sort of follicles because they are now getting fibrotic and they are sort of disappearing. So you'll have single hairs in a follicle. So that is how we diagnose the female pattern hair loss. And where therapy is concerned, of course, topical minoxidil is one of the things we have to go to. And then of course, flutamide works very well, but again, you have to be careful about the hepatotoxicity. Oral contraceptive pills combined with spironolactone also is very useful in female pattern hair loss. So it's a long haul. It's a slow process, but with a lot of hand-holding, but we do get, and as Dr. Anil said, there are a lot of procedures now, which actually we can do PRP, we can do microneedling, we can actually do, we can do stem cell injections. So they also help to stimulate.
I agree, we do it, but is it found to be really helpful, or these
are does help? I think we all have seen very gratifying results with them. Yeah. Because you can't tell a 23-year-old who's so bald that we can do nothing for you.
Absolutely. Absolutely.
May I add a few words?
Yeah, sure.
You know, when everything that Nina and Dr. Nina and Dr. Anil said is spot on with what we also, how we go about the analysis and approach. I'd like to add, because there's so many viewers, that, you know, when a young girl or even an older woman comes and says, I'm losing hair, you know, and you can't see much hair loss, actual hair loss. You can't dismiss it. Itching, dandruff, it doesn't go, follicular eruptions on the scalp. Women who say I lose every 3 months and then it stops and then it comes back. These all suggest patterns of scalp microfollicular inflammation and early hair loss, which could eventually develop into androgenetic alopecia. So we should start young. We should start in a preventive mode also. Then, of course, comes a developed pattern in the frontal area, and as discussed, definitely trichoscopy helps. But on treatments, I would like to say that yes, spironolactone, but I have begun to find oral dutasteride and oral minoxidil of value. But in select more advanced resistant cases, it's not my first line. So my first line would be spironolactone, finasteride, topical minoxidil. Now you get topical minoxidil with topical finasteride. And there are reports to show that they work. Growth factor peptides. These are also found to be very useful in combination with minoxidil, and you can alternate them or you can use them depending on the severity. And one of the newer techniques, apart from PRP as discussed by them, is dermal micrografts, where from the post-auricular area, we take small grafts, and it's used in it's called regenerative, which even Dr. Anil does. And we use it also in females as well as in males for androgenetic alopecia. And in more advanced cases, resistant cases to finasteride, oral dutasteride, with the same precautions as finasteride because it blocks the receptor 1 and 2. And oral minoxidil, is especially in DUPA, the DUPA patterns, the diffuse patterns, Dr. Nina said, and also even in resistant female pattern alopecia, the newer approaches, which we are now adopting for resistant cases, even in younger girls.
I think the only thing I'd like to add on is that when we are giving finasteride and dutasteride, we have to be very careful in these sexually active girls because everyone is sexually active now. And unless you're protecting them with either a intrauterine contraceptive or you're giving them OCPs, it is a big risk factor.
If they're married.
Also, ma'am,
even married, if they get pregnant, you have dutast and all, and so you'll have